And I'd like to take this opportunity to welcome you to this year's Harland Smith Lecture. My name is Jim Rutka. I'm a former chair of the Department of Surgery, and on behalf of Carol Swallow, who's the current chair, who unfortunately is unable to be here today, and Dr. Hong Sun, who is the chair of the Division of Anatomy. I'm pleased to open up the proceedings today for this lecture. It is actually an anatomy lecture. Carlton Smith was a very famous neuroanatomist at the University of Toronto. And I remember using his textbook of neuroanatomy when I was a medical student, poring over page by page his beautiful drawings and his text as I was studying for my neuroanatomy examinations. So there is a tie-in with neuroanatomy and today's lecturer, Dr. Michael Lawton, which I'll mention to you. Just at the outset, I want to acknowledge the land on which we are seated right now. So for thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Anishinaabeg and Mississaugas of the Credit. We recognize that this land has been a gathering of trade and connection for Indigenous people for thousands of years, and it has continued to be a sacred and significant place for Indigenous communities today. I encourage all of us to consider our responsibilities to the land, to the water, and to each other, and to work towards meaningful reconciliation and respect for Indigenous rights, cultures, and perspectives. So as mentioned, Harland Smith, I talked mostly about Smith so far, but Harland, Rita, was Smith's wife, and they were a couple, and they married. They both worked in the Department of Anatomy in those days, and in their name and honor, on behalf of the family, this lectureship was set up and it's hosted, as I mentioned, by the Division of Anatomy. When I was chair of surgery years back, we did run a number of previous Harland Smith lectures, and some of them are shown here. And so, Michael, you're in good stead here in the footsteps of these individuals. Michael, you might remember Ribas, who's a neuroanatomist from Brazil, from Sao Paulo. But he was one of the Harland Smith lecturers not too long ago when I was chair of surgery. A little bit about Dr. Michael Lawton, undergraduate at Brown University. He actually grew up in Chicago. I saw some photos of Michael on social media wearing hockey equipment. I didn't get a chance to ask Michael yet about how he plays hockey, but I think he grew up in Chicago, and that may be the basis of how he put skates on as a child. Got his MD from Johns Hopkins University, residency at the Barrow Neurological Institute, assistant to associate to full professor at the University of California, San Francisco. Main interests are in vascular neurosurgery, of which he is a maven, and you'll hear from him all of his awards. Some of them are listed here, but he has numerous awards. He's traveled the world, and he's a lead authority on all aspects of vascular neurosurgery, more than 1,000 publications. And I worked with Michael to help publish some of what you're going to hear today on the 7 series, in this case, Cavernomas. But it was a real pleasure to work with Michael as I was editor-in-chief of the Journal of Neurosurgery. I just put this at the bottom. He was the first, his institution, I don't know if Michael was the first, but his institution first to insert or implant a Neuralink. Am I right about that, Michael? Yeah, so he may, I don't know if it's, but probably one of his major achievements now is most prominent and influential neurosurgeon on X. And he eclipsed me a few years ago, and he's left me in the dust. So Michael, here's some of the work that Michael has published in the Journal of Neurosurgery. You can see beautiful images, schematics, artist renderings. He works very closely with several artists, I think, at his institution to produce these types of artworks. And he has many hobbies. On the left-hand side, you can see him in his hockey gear, but he also likes the outdoors. And of course, the Barrow Neurological Institute is frequently champions at the softball tournament in New York City at Central Park each year. So with that, ladies and gentlemen, it gives me great pleasure to introduce my good friend and colleague, Dr. Michael Lawton, for this year's Harland Smith Lecture.
Okay. Well, Jim, thanks for that very kind introduction, and apologies for my somewhat failing voice. I caught laryngitis over the last few days. It's actually getting better, but hopefully you can hear me okay. It's a real pleasure to be invited for this Harland Smith lectureship. surgery and anatomy, and the combination of surgical anatomy is really special to me. I love the anatomy. It's one of the things that pulled me in, and spent 7 years actually working with Lawton on the anatomy course for residents for the CNS. And it's really just been part of my blood. And so it's a real connection to this theme here with the lectureship here to be able to talk about that. I also want to acknowledge what Jim said. I owe Jim a debt of gratitude because in writing the 7 Cavernomas book, I felt like I wanted to get some peer-reviewed publications out of it. You put in so much work writing a single author textbook, and the data acquisition, the writing, and so forth. And I called Jim up as I was going on this project, and I asked him, can we work together to turn this book into a series or a collection of JNS papers? And I'd never done that before with all the other books. And he said yes. And it turned into a very fruitful collection of 18 papers. He was very generous in helping usher those through the peer review process without too much pain. And we did it. And so I feel really rewarded having been able to publish both the journal articles and the book. So let me launch in. I have an hour, and I want to save some time at the end for questions. And I realize this is an audience not just of neurosurgeons. So I want to say this at the outset. This is not really a talk just about vascular neurosurgical anatomy, which is very esoteric. I hope this will be a talk that you'll enjoy for the other themes, the cartography, the implications for how we think about the mind and our own future of neurosurgery. So it doesn't necessarily have to go down the rabbit hole of specifics of vascular anatomy, and hopefully you'll see some of the bigger themes come out. So these are my books, my single author books. And I started with 7 aneurysms, went on to AVMs and bypasses, and they've evolved into what I call the 7 series, which is not only a series of books, but taking all the cases that really are the grist for the mill and turning those into educational videos that become teaching resources and also social media prompts that help people day to day learn the craft. And so I dove into all of these books with the idea of, well, they kind of turned into taxonomies or ways of thinking about these different pathologies in an organized way. There's so much disorder and chaos in how we think about these pathologies, whether it's aneurysms, AVMs, the different types of bypasses, that coming up with systems for cleaning up the dirt or ordering the chaos was helpful for me. And this slide sort of captures that taxonomy that infuses the aneurysm book, the AVM book, and the bypasses. And what you'll see at the bottom is the taxonomy that we came up with for Cavernomas. And with each of the books, they have a metaphor. The metaphors are to the right. The first one with the aneurysms was dancing and taking a complex surgery and breaking it down into individual steps. With AVMs, it was maps, sorry, not maps, but war, and thinking about how you attack an enemy like an AVM in these maneuvers or steps to do combat. With bypasses, you're building things, so it was architecture and blueprints, and that was our theme for 7 bypasses. And with Cavernomas, it became cartography, and you can see the map there. This is a quote from my good friend John Golfinos, who said that he proposed a grading system for grading systems, to give me some grief about this, because he thought that I was producing too many taxonomies or grading systems. And he came up with a system of assigning points. You'll recognize the Spetzler-Martin reference here for number of authors, whether I'm one of them, whether a rock curve was in the paper, and whether it had pretty color pictures. And depending upon the grade, that would determine whether you should take the time to read the article. But we've done it again with this, and I'm going to present to you the framework for Cavernomas, which begins with a taxonomy, talks about all these various themes with subarachnoid corridors, the triangle concept, arterial landmarks, safe entry zones, and technique. And this is how the cover will look. It's finally done. It's been shipped to TEMA. And so hopefully by the fall, you'll see this actually at the CNS meeting. So I want to begin with a case example. This is a midbrain cavernoma. And what you can see here is a lesion that's in the interpeduncular fossa over here. Hopefully, can you see my mouse? Yeah, there we go. It's an interpeduncular cavernoma subtype. And once you define the subtype for a lesion like this one, everything else follows. You get the craniotomy that you need, the approach, which is a contralateral transsylvian interpeduncular approach. The triangle that you go through is the carotid ocular motor triangle here. And the safe entry zone, if necessary, is the interpeduncular. So that all flows from your assignment of type and subtype, or the taxonomy. And this is just a quick clip that shows you some of the anatomy. You go down the sylvian fissure, you get to the optic nerve. Here's the optic chiasm. And when you do this dissection, you can lift the frontal lobe from those structures. Here now, we're moving into the space by the third nerve. And now we're down in the interpeduncular space. You're looking to the contralateral P1 and PCOM. Here's the ipsilateral PCOM, which I'm going to divide. Sometimes the PCOM acts as a tether that pulls up the shoulder of the P1. And when you cut that, it drops the shoulder, and you can see how it opens that corridor. Now you're seeing the mammillary bodies, which adhere to the P1s. Here now we're at the opposite PCOM. And as we go into that interpeduncular fossa here, we go between the thalamoperforators. We can begin to see a little bit of staining there on that inside edge of the contralateral peduncle. And now, for the first time, we get to the cavernoma, which comes into view. So this is a great example of how not only is anatomy so critical, all of these things that you learn anatomically come into play here. And here's that transsylvian contralateral exposure that goes right across the basilar apex to get this lesion out. Now, this is a nice slide that summarizes what you just saw. It's the interpeduncular midbrain. Notice it's a binomial taxonomy that has both a subtype and a type. You can see from the leftward image how your understanding of this anatomy and its relationship to some of these neurologic syndromes that you learned in medical school studying stroke syndromes is all coming back into the picture here. The Claude syndrome is a perfect example of how it's not just stroke, it's also cavernomas that can cause these. And as we go to the right, you can see the surgical anatomy that's relevant here with the craniotomy, the trajectory, and here's our anatomical triangle. In this case, it's the carotid ocular motor triangle, which brings us right to the right spot for our entry. Here's another example. It's a very similar lesion in a very similar location, but we're going to classify this a little different. This is midbrain, so it's the same type, but it's a different subtype. We call this a periaqueductal because you can see here, it sits around the mouth of the aqueduct, rising up into the third ventricle. And so for this, we'll choose a bifrontal craniotomy, a contralateral transcallosal transchoroidal fissure approach, and we'll get to it from the top down. And so with this video, what you're seeing is the interhemispheric fissure. Gravity is pulling down on the interhemispheric or on the frontal lobe. And here I've opened up the choroidal fissure completely. And now we're looking into the third ventricle, and we're seeing this cavernoma here coming into view. This is a little cystic component on the top. Here's massa intermediate here, so we're behind that. And now you can see in the back of the third ventricle, the pathology that I'm pulling out from underneath massa. And as we look, this is the floor of the third ventricle. The lesion comes out, and you'll see in a minute the aqueduct here coming into view, which helps to define this as a periaqueductal lesion. And with this view, you're working interventricularly. Here's the aqueduct right here. So you see how this sits right adjacent to that. And so this was a perfect approach from the top down to get that exposure. And you see the beautiful window created through the choroidal fissure. Here's again, that summary picture that shows you the different clinical syndromes. You can get either a Noth-Nagel syndrome or a Claude syndrome, depending upon its relationship to the decussation of the superior cerebellar peduncle, whether it's ipsi or contralateral. To the right, you see the craniotomy, you see the surgical anatomy that we saw in the video, And it's all relevant to your approach. So those are two case examples just to whet your appetite. And the taxonomy is based or derived from my personal surgical experience. You can see the numbers here. We do a lot of these in Phoenix at the BNI, not only because our relationship to Mexico, where there's a higher incidence among Hispanics, but also the BNI is a real magnet for these particular referrals. This slide summarizes the entire taxonomy. From top to bottom, there are 35 different subtypes. There's 7 different types. And you can see in the grid to the far left how the types depend upon the regions of the brain. The subtypes depend upon the surface where the lesion presents. So for all of these cavernomas, what you're looking for is where is it located and what surface within that region does it present to. So for the brainstem, this nicely shows you the different surfaces of the brainstem. The types are either midbrain, pons, or medulla, but the subtypes depend on whether it's anterior or posterior, lateral or posterolateral, or anterolateral. And so the combination of the type and the subtype uniquely defines 16 different subtypes within the brainstem. And it's not just the surface. When you think about going deeper to the surface, this is the zones beyond the surface that are color-coded. And you can see the different zones in the midbrain, pons, and medulla. When we get to the other types, we have the thalamus, we have the basal ganglia, we have the cerebrum and the cerebellum. And so again, with these, it relates to the surface. And so for the cerebrum, it's either convexity, medial, basal, or sylvian. And for the cerebellum, we have the classic surfaces of the cerebellum, like the petrosal, tentorial, suboccipital, and so forth. So this is the taxonomy, and I think it's pretty self-explanatory. It's anatomically based. If you're a fan of anatomy, it's all tied to all of the things that Lawton has taught us over the decades of his work. Now, the next thing is the real value of taxonomy. When you have a taxonomy and you define a lesion by that binomial system, it then tells you how to approach the lesion surgically. And that's where we come to the subarachnoid dissection. So these are the various surgical corridors to get there. For the convexity lesions, we have transgyral, transsulcal, and combined approaches that get us through the convolutions of the cerebrum. When we talk about the sylvian fissure, we have a number of different approaches that get us to different areas around the sylvian territory, but also to these deeper levels into the basal ganglia, into the thalamus, and into the midbrain, where you see those level 4 designations down at the bottom. When we talk about the next corridor, we've got the interhemispheric fissure and the ventricular system. And so look at all of the arrows here that go through that interhemispheric fissure into the lateral ventricle and through the choroidal fissure to the third ventricle. And we can again get all the way from the convexity up top to the periaqueductal region down below here at the 4th level. When we talk about the tentorial fissure, again, varying depths of our journey from the tentorial surface of the cerebellum up here all the way down to the points on the midbrain down deep. For the pons, we have the cerebellopontine cistern shown here. For the medulla and the lower pons, we have the cisterna magna to navigate. And once again, you can see the different variations of approach through these trajectories. So the next thing I want to bring out is this idea of triangles. For the 7 AVMs book, we introduced what I call the box concept. And what that meant was to take something complicated like a brain AVM, simplify it to a 6-sided cube or box, and paste on these various anatomic features like the draining veins, the feeding arteries, and the anatomical eloquence. And there's that, but then there's also this idea that the box transitions or breaks down your surgical dissection into phases, where there's the peel phase, which is the top of the box, that initial surface. There's the parenchymal phase, where you're going around the 4 sides of your box. And then finally, the ependymal phase, which is the sixth side or the deep surface of the box. And that helped to kind of plan where to look out for specific anatomy, where to look out for eloquence, where you needed to protect the draining veins, and so forth. We wanted to do the same for cavernomas, and our concept for this different group of this different pathology is the triangle concept. And the analogy here is a gun. And when you shoot a gun, what you're really doing is you're aligning your front and rear sights. There are two sights on a gun, and it's the alignment of the two that actually aims the barrel so that you can hit your target. And so when we translate that analogy to cavernomas, what we're saying is that you can't just think about your strategy in terms of a craniotomy or even just an approach, because you need really three elements to your strategy. You need to think about your craniotomy, which by this analogy is the rear sight. You need to think about the barrel, which is the surgical approach. And then you really need that front sight, which is the triangle, to align the two and hit your target, which is the cavernoma. And so we needed to develop this system of triangles. If you think about cavernous sinus surgery, you think of Parkinson's triangle, Doling's triangle, Hakuba's triangle. They're all of these triangles that allow you to orient yourself to the cranial nerves and find the right space for the particular pathology of interest. The same idea is true for brainstem, and yet we really didn't have this established system of triangles. And so we really worked at formalizing that. There are 14 triangles now. We invented some of these. Others we simply just pulled in because we all know these things. For example, carotid ocular motor triangle over here is one that we're all familiar with. And others like the infragalenic triangle is an approach to the pineal region that we all know, but by assigning some names to these triangles and really formalizing this, it, I think, becomes part of our discourse, our nomenclature, our conversation. And so this is what we set out to do. And you can see the 14 different triangles laid out here. So this slide embodies that triangle concept. When you are thinking about your surgical strategy, you really should think about the three elements: your craniotomy, the subarachnoid corridor that you're going to take down through the subarachnoid space, and then what triangle are you going to use to steer the way to finally aim at the target. This table summarizes all of that. So if you think of all of the different concepts that I've been mentioning so far, what you see is the taxonomy over here with the type and subtype and the 16 different subtypes within the brainstem. Here's your surgical approach, here's your triangle, and here's safe entry zone over here. This is like your Rosetta Stone that ties all of this together. So even though this is a very busy slide, it has everything there. And so, you know, that works really well for the brainstem. What we found is it doesn't translate as you move from the brainstem to the cerebrum. In the deep cerebral spaces, you know, there are 9 different subtypes here. There are 3 in the basal ganglia and 6 in the thalamus. There are some triangles, supracarotid, septocaudate, etc. But it starts to break down a little bit here because there aren't as many cranial nerves and there aren't as many structures that give you that triangular guidance. And it also tends to break down up in the cerebrum here because for this part of the brain, we're working through the convolutions and not necessarily through cranial nerves that provide us with those discrete triangles. But I think as a concept it works, and this illustration shows you that. If you think in terms of type and subtype for the brainstem, and you see here the 16 different subtypes, if you were to think only in terms of craniotomy, what you would find is that there really are only 6 different craniotomies to choose from, and that's not specific enough to take you through your surgical strategy. But when you add the approach, and by that I mean the subarachnoid corridors, and you add in the triangle, what you see is that that specifies where you need to go to get to the target. Now, arteries are part of that anatomical landscape, and one of Rowton's really great contributions was to develop these alphanumerics for the cerebral arteries. And the only paper I wrote with Dr. Lawton was doing the same thing for the cerebellar arteries to complete that whole system of alphanumerics. And we did that for the bypasses. We wanted to provide some better labels for describing bypasses. But as it turns out, these arterial alphanumerics provide you with associations for the different subtypes of brainstem cavernomas, meaning that every one of those 16 subtypes in the brainstem has a specific arterial address that corresponds to its location. So if you use the arteries and get to that arterial address, you will arrive also at your cavernoma. And these illustrations just show you how you can use the arteries to take you from point A to point B to point C as you walk along those arterial trails to get to the targets. So cartography, this is sort of the metaphor for the book. And at this point, we had done all of this work, putting some of these concepts on paper. And the metaphor that really worked for me was to skiing. If you're a skier, you'll recognize Jackson Hole. But when you show up at a mountain like this, what you find is there's so much information all at once that you need to digest to have a good day on the mountain. It's where you start, what lifts you're going to choose, what trails you want to run, and so forth. And these trail maps condense all of that information down to a single page that you can have in your pocket. And the artist that does the vast majority of these trail maps, these mountain maps, is this guy over here, James Nehughes. And his process is fascinating. There's a great book on his work. And what he does is first, he'll fly over the mountain in an airplane, surveying the landscape and the topography. He then hikes the trails and gets a sense for the feel of the mountain. And then he'll start to sketch the mountain in pencil. And his precision is incredible, down to the trees and the curves of these runs. Then he'll ink the illustrations with his paint and ultimately end up with these kinds of illustrations. And these quotes are really nice. These are from that book I mentioned. He twists and alters the landscape so you can see different dimensions of the mountain portrayed on a single piece of paper. Here's Big Sky, another incredibly vast mountain that's really like, it's almost like a pyramid. There are about 270 degrees around this mountain, with sides over here and over here that are really on opposite sides of this peak. But he flattens it and gets it all into this single page. And this quote is also great. You can just tell how something is going to ski without seeing it. If it has a black triangle or blue square, you feel safe with Jim's map inside your pocket. It's magical. And so we chose the cartography idea for the metaphor because it integrates the things that are important on a map and translates that beautifully to cavernomas. And I then asked my illustrators to then make maps for this book. This is Danny. She decided to make a map, which is this plate carré map here. It takes the Earth and it flattens it or rectangularizes it, as you can see there. And what she did was she unfurled the brainstem, and you see the different subtypes and the different colors here. You see the craniotomies and the approaches with these arrows. You can see these safe entry zones as the dotted lines, and those arterial landmarks that provide those alphanumerics over here. And so this was her synthesis or her cartography for the brainstem. This is Kristen Larson. And what she did was to do a different map. This is the equidistant map, where every point on the Earth's surface is converted to its relationship to the North Pole. So it circularizes the map. And she did the same with the brainstem, showing the midbrain, pons, and medulla circularized around the aqueduct here at the top, which is our North Pole. And you can see the different subtypes in the colors. You can see the arterial landmarks. The hexagons are the craniotomies. The arrows are the surgical approaches. And again, the dotted lines are the safe entry zones. So this map integrates all of that information in another form. For those of you who like subways, and I think Toronto has one, This is the arterial tree shown in subway form, kind of analogous to the Manhattan subway up here. And this is Peter Lawrence showing the different arteries and the way that you can use the arteries to kind of follow and guide your way to your target at where X marks the spot to the brainstem. Here's the view from the back showing more of those different routes. So that's the creation of maps. And that was fun to kind of pull together all the different concepts for 7 Cavernomas. But how do you use the map? One thing is this idea of orienteering, and not just being navigated in the operating room, but actually thinking of yourself as an orienteering neurosurgeon. And it's very easy just to take the images that are given to us by stealth and just sort of see whether or not we're on track. But it's analogous to driving in your car and using Google Maps. If you simply plug in your destination and wait for your next instruction, then you are becoming a passive consumer of knowledge that really isn't making you a better driver. It's not illuminating your knowledge of the street, but it's you're becoming dependent upon this. And I think it's important for us as neurosurgeons not to be navigated or overly navigated, but to think of us as orienteers. It's important because it makes you more engaged in your patient selection, in your approach selection. It can help you surgically practice or rehearse. And most importantly, intraoperatively, it helps you use your anatomy as your guiding, as your guidance system rather than the computer system. And that gives you the key things that you need as a surgeon: to be calm, to be clear-headed, and to be confident. And that ultimately will translate to better outcomes, I believe. So where's orienteering so valuable? Well, it's valuable when it comes to this concept of safe entry. So if you orienteer yourself to that point where you think the malformation comes to the surface and you get there and it's not there, it's not exophytic, or there's not any outward evidence of the pathology, then you have to use a safe entry zone. You have to violate normal tissue to get to the pathology. This illustration shows the 21 different safe entry zones in the brainstem with these white lines. And so it's really important that you, as surgeons, know exactly the anatomy of these safe entry zones. These are some of Kristen Larson's illustrations that map out the not only where the lines are located on the surface, but more importantly, how they're oriented within the tissue, because it's not just the line on the surface, but you have to angle your trajectory sometimes through the tissue to get there. And these maps will help you understand, for example, that relationship that takes you around the pyramid in the medulla. These are Danny's computer graphic maps that show some of those safe entry zones, again, in the midbrain and the medulla, and their relationship to the underlying tracts and nuclei. And here's Peter Lawrence, again, with his maps showing how these safe entry zones relate to the surgical anatomy seen from the perspective of the surgeon. Now, another way that we use the maps is to educate. And one of the traditions at the Barrow is to call everybody together at the end of the day, usually with a page. It used to be film rounds with Dr. Spetzler in front of the alternator, looking at films on a light board. But today it's now this beautiful room at the BNI with a big screen like what you have here, where we review our films. And this idea of education is important in maps. And here's a great quote, again, from the Nehew's book. I'll read this one to you. It says, "My kids haven't been to the places I've been, but they can look at a map and imagine. Before I took them to Whistler, we spent weeks looking at maps. Their eyes would light up with the promise of all those black diamonds and steep lines. It was like the maps were a portal to a different world." And this is Sugar Bowl. This is the mountain where I taught my kids how to ski. They were on ski team for 14 years and became far better skiers than I am. But this idea of education is important because it's hard for this rising generation to have the the experience or the numbers that I've had or that Dr. Spetzler has had with this pathology. And so it's important to teach. And one of the things I've enjoyed about this project is that the anatomy of stroke syndromes is so relevant to cavernomas. And these are just some illustrations that show these wiring diagrams. As Jim mentioned, I was an engineer. I love learning neuroanatomy as circuitry, neural circuitry, and its relationship to the bedside was also just fascinating to me. But that's a lost art, and to kind of rekindle that with some of these maps that show these circuits. This is the circuitry for the intranuclear ophthalmoplegia. But when you dive in, you know, there are 5 different types of INOs, and the more you know your anatomy, the more you understand that circuitry, the more astute you are at the bedside at localizing exactly where that cavernoma sits in relationship to the MLF, for example. Here's the middle peduncular pontine, and again, there's a classic stroke syndrome, the Marie-Foy syndrome, and you can see how the wiring diagram explains all of that to you. Here's the pyramidal medullary cavernoma showing the relationship to the pyramids and the hypoglossal nerve rootlets. Again, these are maps, these are wiring diagrams that tie together the anatomy and the bedside findings. Another way that you can use maps is to explore. And exploration is a really important part of what neurosurgeons need to keep doing. This is the Royal Gorge. Right next to Sugar Bowl is this incredibly vast cross-country ski area in California. And when the snow is not good at Sugar Bowl, we would go off into the Royal Gorge, and you can see this incredible system of trails that take you from Sugar Bowl, which is actually all the way over here. That's Sugar Bowl Mountain, and you could ski down these meadows over into this area back here. And if you were really pushing it, you could get all the way out here and look down into the gorge where you could see the mouth of the American River on its way to Sacramento. And this quote is another great one. It says, "I would play a game in my mind. I would look at the trail maps and imagine the spaces between the runs. I would fantasize about what the mountain was hiding, what wasn't being depicted, sniffing out those special places. Is that a cliff? Is it dangerous? Is it spectacular?" You get fluent in looking at those maps and finding the potential, the possibilities just off the trail. It's one of the things I loved about cross-country skiing was that you could get deep into this wilderness and find all of these really unique meadows and vistas and views. You know, sometimes it's just a matter of taking the time to explore and finding what you can find. Well, here's that guy again. This is Alex Honnold, and his claim to fame is scaling El Capitan. And how he did that was by creating a map. And this map chronicles each and every step of his journey from the bottom all the way to the top. And he did this free solo, which means by himself and without a rope. So one mistake meant that he would fall and fall to his death. This picture here sums it up. You can see here, as he's nearing the end of his climb, how dangerous this was. But he did it again by creating a map and practicing every one of those steps from top to bottom and bottom to top over and over again over years. This story is beautifully depicted in this movie, which you can, it's one of the best metaphors for neurosurgery that I've ever seen, or by reading his book. And I actually had the chance to meet him at one of our meetings because he was a guest speaker. But in neurosurgery, we have opportunities for free solo as well. This is just a list of some of the surgical approaches that I've tinkered with or popularized. And I think what I've enjoyed about that process is just, again, finding those spaces that are off-piste or outside the map a little bit, and finding that something new or different that makes the approach a little bit better or a little bit apt for the particular lesion of interest. And I think for all of you, the message is that we all have something to contribute and that we need to do our own free solos in our unique areas of specialization. You need an explorer's mindset. You need an innovative idea. You need to test your ideas in the cadavers. You need to rehearse. You need to wait for the right patient at the right time. You then need to execute. And this is a sign from the Phoenix trails. And if you look here, it says, don't be a trailblazer. They want you to stay on the trails. They want you to not go into these closed areas. And so I say here at the bottom, expect resistance. This is not something that's widely encouraged, but I think for all of us, if you have that innovation, you need to pursue it. So I've got about 15 minutes left, and I want to finish with the mind, because the process of thinking about cavernomas took me to areas that I didn't really expect it to take me to. And so I'll finish with these ideas. So when we think about resecting the cavernoma, there really are two ways in which I think about it. The first is over here on the right with the brainstem lesion. And what I do for those is I get to the pathology. I go inside the pathology here to kind of empty it out, to core it out, and then collapse it internally. Once it's collapsed like a raisin, then I can go around this plane, being very gentle and conservational on the brainstem tissue adjacent to it, and then usually pull it out like you saw in some of those videos. When we get to the cerebrum, it's a little different. We tend to go around the capsule. We're a little bit more invasive because, many of these patients present with seizures, and there's a gliotic rim around these, and some people even go into the gliotic lesion and take that out as well. And so there are different techniques, the intracapsular and the extracapsular. Well, when we were doing the cerebral cavernous malformation work, what we wanted to do is not only evaluate our traditional outcomes that we measure with modified Rankin, but we wanted to be particularly hard on ourselves. And we did all this work retrospectively, unfortunately. So we had to go back and develop what I call functional decline, which are looking for the things, the telltale signs that we hurt patients more than what our modified Rankin scores were telling us. So we look for these things. We look for whether or not they went to rehab beyond 6 weeks or physical therapy beyond 6 weeks, whether they needed additional brain imaging beyond 6 months, whether they had office visits beyond 6 months, and whether they had referrals to psychology or psychiatry. These were the retrospective signs that patients were suffering that might not show up in a modified Rankin score. And these were the things that were particularly of interest to us. And so when we looked at our cavernomas in the cerebrum, you can see them depicted as the lesion itself over here, and as dots here to simplify. And over here, these were our surgical corridors that we used to get there, mainly through sulci, but sometimes through gyri and sometimes through combinations of sulci and gyri. And so when we looked at our outcomes, we had our modified Rankin scores here, which you can see we did pretty well. Only 10% of our patients were neurologically worse if you just judge them based on modified Rankin score. But when you added this functional decline, we more than doubled the amount of patients that were hurting. And so we ended up with nearly a quarter of our patients that we could look at to see whether or not, or learn from them where these areas of potential harm were coming from. So this is basically an impossible slide, but it shows the different parcellations of the cerebrum shown as functional region and their feature importance, meaning their statistical association with that poor outcome as defined by that functional decline. And these parcellations are based upon the Human Connectome Project and that famous Glasser paper in Nature. And from that analysis, what we came to was that there were 7 areas of interest that were causing harm. And I'll just walk you through them. The first was the SMA, and it makes sense when you think about how dialed in we are to the motor cortex. What we do is we cheat forward, and we cheat into the supplementary motor area to get these lesions that are bleeding in the motor strip. And so the SMA actually turns out to be a very eloquent area that causes patients trouble, and that's depicted here. If we look at this next area, the left anterior insula, you can see how this region is also a trouble spot, and it has to do with its relationship to motor system and also the salient system, the salience network, which is depicted in green. The cingulate gyrus turns out to be very important because of its relationship to both the default mode network and the salience network, and it's really laid out here along the cingulate gyrus. And this is a very important corridor as we get into the interhemispheric fissure and into the ventricular system. And so that became something that jumped out. The visual system is an obvious one for obvious reasons back here. And then the last two are the right frontal pole, which is key in the central executive network, and obviously the mesial temporal lobe in memory. So what we came to was that these large-scale brain networks that are really now coming to light with the advent of things like omniscient and the omniscient guidance in surgery, that these networks help explain some of those findings, that we're getting into these networks and doing some disruption there that really affect patients' outcome and quality of life. This slide is just meant to show you these networks and how vastly arrayed they are through their many parcellations throughout the cerebral cortex. That's the parcellations on the cortex, but there's also the white matter tracts beneath them that connect those parcellations. And so when you think about the sum total of the parcellations and the white matter, the brain becomes a very complicated system to try and unravel. Penfield did a really amazing job in defining the homunculus, and his way of interpreting the organization of the motor strip and the sensory strip was really quite accurate, because this concept of somatotopy really works. You can literally map out the relationship of, foot motor cortex or hand motor cortex with motor or sensory to these locations on that part of the cortex, and that guides your thinking or understanding of that particular region. Well, as it turns out, we wanted to do the same for the rest of the brain, and it's not so easy. Probably the best we could come up with was those 7 areas of what we called non-eloquent eloquence, these areas in green that turned out to have functional importance in our cavernous malformation data set. And so if we add to traditional eloquence, motor and sensory and speech and language and visual cortex, if we add to that those other regions, we get these blue and green areas. So our region of eloquence is expanding. When we looked at ways to try and come up with a better map, we looked at all the different parcellations. This is that Glaser map down here from the Connectome project, and this is the flat map, which takes the cerebral cortex, it incisors it and unfurls the cortical convolutions. One of the things that came out from this analysis was this idea of triads. These areas where the central executive network combines with the default mode network and the language cortex to kind of interpose between the other sensory symptoms like motor, sensory, visual, and so forth. And what this is telling us is that evolutionarily, we all have the same systems, the same basic sensory and motor systems. But what makes human beings different from rats, for example, is that we have these triads that allow this information to then enter these higher networks that feed language, that feed our internal processing network, which is the default mode network, or the central executive network that allows us to do these higher cortical tasks like creativity and intelligent function. And this is what's differentiating us from lower species. So then when we add traditional eloquence to that non-eloquent eloquence to triads, you can see the map gets even fuller still. And so what we're moving towards is this idea that there really isn't any non-eloquence in the brain left. The only way that there's non-eloquent brain is that we don't really understand what it's doing yet, and we will someday. And that really comes to light with this example. If you think about skiing, You're using so many, if not all of the networks simultaneously. We think of networks as individual one-offs, but when you do something as complicated as skiing down this mountain, you're using everything: vision, motor, sensory, auditory. It's all active in order to get down the mountain safely. And so even to be human really is, we have to think about the brain, all of the brain working in synchrony at once with all of our networks, all of our systems firing together. And that leads us to this idea of brain states. This just shows you the way that the different networks light up in the different emotional brain states, and how each is so uniquely different. We tried to come up with a map for this too, and we failed. The best that we could do was to analogize with what I've just walked you through, how we've gone from surface anatomy to the homunculus, to the connectohomunculus, to this idea of brain states. And the thing that struck me was the celestial map. You know, centuries ago, when the Greeks looked up at the sky, they came up with these simple celestial maps with the constellations. But as we've developed the telescope, and then the space telescope, and then the infrared telescope, what we've been able to do is to probe deeper. Each point on that celestial map becomes its own galaxy. And within that own galaxy, there's infinite amounts of understanding or knowledge to be gained within that. And I think that's really how we all need to view the brain. The brain is this ever evolving, ever deepening universe that we need to keep probing and delving into. So I kind of finished trying to come up with what we call the connectohomunculus, and not really arriving at anything meaningful other than this sort of analogy. But over here, where it says neurotechnology is one of the takeaways. And that leads me to the PRIME trial that Jim referenced. We are the site for the PRIME trial. I know you guys are recently onboarded with that, so I'm sure very soon I'll be reading in Reuters about your first patient. But we've done 4 so far. You're familiar with the device, so I won't spend much time, but this just summarizes the 64 different threads, the 16 electrodes on each of the threads, and the circuitry and the battery power that go into powering the device. When you think about the old systems, the Utah arrays and the DBS, these are so archaic compared to the N1 device. This device, this is the thread electrode. It's very thin. It's a fraction of what you see in these other implantables. And the robot does all the work. It's a giant sewing machine. What it does is it takes a picture of the cortical surface and it individualizes the insertion sites so that you can avoid the arteries and have an atraumatic insertion. This is Nolan Arbaugh. He's patient 1 for us. And this is his surgery. So this is the robot in action. It picks up this thread, it then brings it to the brain surface and implants it in that pre-designated spot. And it can do this procedure, if you just let it fly, in probably 10 minutes or less. It took us about an hour with Nolan. But immediately in the recovery room, you can see the signals coming from his brain. And Elon came out for the day. And it was fascinating to get to see him and his team at work. This is Nolan in my office about a month after the surgery. This is a little game that shows him tracking that blue square. And again, Nolan is a quadriplegic. He had a swim accident. I'll show you a video in a second. But he's able to do this just by thinking about how he would want to move his right hand, because that device is in his right hand knob. He's thinking about how he would move his hand if it were attached to a mouse, even though he's paralyzed. And the speed is unheard of. It's if you were to try and track that yourself, you would probably struggle to keep up with him. And this is him doing what he loves to do, which is to play video games with his friends. But let me show you this video. And it's about 3 minutes. And let me just run this for you.
Was working at a summer camp. I didn't dive into the water. I didn't jump off anything super high. I had hit my head somewhere along the way, I guess. Immediately I knew I was paralyzed.
Nolan had a tragic accident and it transected or severed his spinal cord. He lost his ability to move his arms and legs and became completely dependent on others, including his parents.
I've been following Neuralink ever since he got announced. And the day that human trials opened up, I gave Nolan a call.
And Nolan seemed very, very excited about it. And he was really excited that if he could benefit anybody in any way, he thought, let's go for it.
This trial needed somebody just like Nolan. So many people think about this device as something that's scary. And Nolan stepped up. He demonstrated that this was not something to be feared, but something that would change lives in a positive way.
He just got pushed right through the entire process and got selected as the first candidate within a couple of months.
It's very exciting stuff, and I'm really happy to be a part of it. And I'm happy that they chose me.
That's an amazing gift that Nolan has given humanity, to step forward first and make it easier for everyone else who's following. On the day of Nolan's surgery, there was incredible energy here at Barrow. There were people coming from all corners of the world, from the top of Neuralink to the top of Barrow, and all of us were focused like lasers on this operation and getting this device into Nolan's brain safely so that this could make history. When I first met Nolan, it became obvious that he was the guy for this. He was brave. He had no fear about the procedure. He wanted to help humanity. He's a happy person.
Hey, what's up?
He has a great sense of humor. He connects easily with people. His vision was so far on the horizon that he didn't care about all the scary details in between. I can only imagine what it must have felt like for Nolan to see the activity of his brain flashing on the computer screen. For us, it was like we were unlocking this secret language that never before we had access to.
In day one of being able to get cursor control, he beat the world record.
When I see Nolan driving that cursor with his thoughts, it's pure magic. In the days and weeks that were to follow, Nolan was going to undergo this incredible transformation where his control of his world was through a mouth stick poking away at a computer screen. Going from that to having his intentions, how he would want to move his hand if he could, drive the cursor and control his world.
The things that I'm able to do on this computer now should not be possible with me in my situation. I was playing a video game with my buddies from college. Not only was I able to play with them, but I beat them in a game of like a game based on speed.
What we've accomplished with Nolan is really just the first step. What waits for us ahead is so much more. The trial gives new autonomy and restored hope to Nolan. And for us, it gives this incredible opportunity to understand the workings of the human mind.
I'm very optimistic about what BCI could mean to humanity. We're really hoping to help those with terrible spinal cord injury be able to get their digital autonomy back.
What this trial has shown us is that there is something more that we can do for these patients. We can help them take back control of their own lives.
I wanted to show that because it gives you a good flavor for how this dramatically changes his life and the lives of all the patients that came. This is what's coming down the pike. That chip will not only be connected to cursors, but to robotic grippers. And our patients 3 and 4 have been ALS patients who are completely locked in, ventilator dependent, on life support, but now can communicate through their cursor control and their interactions with the computer. This is Stephen Hawking. And at the end of his life, he was communicating through one cheek muscle that was still alive on his face. And these patients can actually go on living locked in with these chips now, which I think will change the course of that disease. This is probably sums up how Neuralink is viewing the future. This is how they want this to go. And so we have to be ready. There's great technology now that's coming. This is the precision device that's non-implantable. It's laid on the surface. It's a micro ECOG array. This is my first case with the device. It's an example of how we can all become functional neurosurgeons if we're not functional neurosurgeons per se. We just have to get in the game and start learning about how the brain is working. So I'll wrap up here. This was one small step for us as an institute, but a giant leap for the mind of mankind. And, I presented to you this next in a line of taxonomies in the book. But the journey has been amazing. It's changed. It started off thinking a lot about brainstem, which was sort of our surgical no man's land, which has become routine. But in the end, it's the cerebrum and the cortical work that really has made the biggest impression on me. That has transformed from this silent area to this truly immensely eloquent area in my mind. And our challenge really is to see if we can map the human cortex like we've done for the brainstem, and more importantly, crack the code, the electrical signal or the electrical language that's driving that. When I think about BCI, we are looking at basically two lobules, hand knob of motor cortex and language. But the cortex is incredibly vast. And imagine if we really are able to listen to all of that and to tie into the rest of the human cortex, what we're going to learn in the decades ahead. It's a fascinating topic. If you think about movement or intelligence or plasticity, emotion, even consciousness and memory, these are the things that, we as neurosurgeons should be tackling head on. And yet, when I think back on my 28 years as a neurosurgeon, I haven't devoted any attention to these things. And I regret that. I feel like this journey with 7 Cavernomas has made me realize that I need to sound the alarm that we all need to start paying attention to these aspects of the mind, because we are the only people that have access to the human brain through our craniotomies and our routine cases that we do. So I think this is my last slide. I leave you with this idea of committing to the mission to explore the mind by studying human brain function, turning your operating rooms into laboratories of the mind so that you can capitalize on our access, and turn yourself into a functional neurosurgeon. Even if you're a vascular neurosurgeon like me, you can be functional by bringing this technology into the OR and learning. It takes just that commitment. It takes money. I'm hopeful that we can build something like what I saw across the street in sick children's, a beautiful building that's focused on a mission like that. And that's what we're trying to do. So with that, thank you so much for your attention.
Michael, thank you. That was an awesome lecture and so worthy of the Harland Smith lecture. I tell our residents that you may not know what's wrong with your patient. You may have a neuronavigation system that goes down at the time of surgery, but if you remember your anatomy, you can always do the right thing for your patients. And this was a phenomenal lecture based on anatomy. So as I look over the whole front of surgery and think about very complicated types of surgery that would involve, let's say, conditions like biliary atresia, abdominal aortic aneurysms, maybe hypoplastic left heart syndrome, where the surgery that's involved is technically so challenging. You've seen an expert today talk about neurosurgery and approaches to neurosurgical lesions that really require a concert pianist's attention and performance. So Michael, thank you. And on behalf of the Department of Surgery and the Division of Anatomy and the Division of Neurosurgery, just a small token of our appreciation. Also contained in here are a couple of University of Toronto ties, which I created myself in my tie designing days, but I hope that you'll enjoy them, one from the Department of Surgery, one from the Division of Neuroanatomy. So thank you very much, Michael, for all of this. Thank you. Okay, folks. We'll take a brief break, but for residents and fellows who are here, Dr. Lawton is going to be giving another lecture in about 20 minutes or so. Let's take a coffee break. And then we have some resident case presentations. We can probably load presentations onto Dr. Lawton's slides projector during this break. Okay, thank you everybody for coming. Michael, thanks very much.